The Bridge program creates that opportunity where we are trying to marry clinical excellence with community outreach and patient advocacy.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guests are Dr. Sara Myers and Dr. John Alexander. Sara is a surgical oncologist specializing in breast cancer, and John is an orthopedic cancer surgeon specializing in sarcomas. And together they lead the new James Bridge program, which focuses on early onset cancers in young adults and will be a real game changer for younger cancer patients in Central Ohio and beyond. They'll fill us in on this exciting new program and what it means. Welcome to the podcast.
Thank you for the opportunity.
So before we actually get started on Bridge, Sara, you just made it here in time for our recording session, and you're still wearing your scrubs. Can you fill everyone in on what you did this morning?
Yes. So I feel very privileged that my area of clinical expertise is also in young adult and early onset breast cancers. And I have the opportunity this morning to operate on to younger individuals. And I think that's one of the really unique assets about the Bridge program is that the program involves key stakeholders from across cancer treatment spectrum, individuals who are kind of in the thick of it, treating these younger patients. They see the challenges that this population may have and are deeply committed to improving care and quality of life for them. And they're in scrubs sometimes.
Also, as for the need for the Bridge program, I think you just kind of filled us in on that. But John, why don't you sort of fill us in when you say Bridge program, what do those words mean, and who was sort of the audience of patients, the cohort of patients that you will be seeing?
Yeah, so the Bridge program initially started as a renovation per se of our existing adolescent young adult program. And we realized as we were putting this program together that we were seeing increasing rates of cancer and new cancer diagnoses in the patients age less than 50. And it's sort of at an alarming rate in Ohio and across the country. And
so we've been seeing a lot of that in the news.
Yeah, it's all over. And so in response to that, as we expanded our existing program, which included, again, the 18 to 39 range, we realized, we really have to expand this to include all patients between 18 and 50. So it really includes patients who are diagnosed as a young adult with a pediatric diagnosis. So things like Ewing sarcoma, acute lymphoblastic leukemia, and then also sort of traditional cancers that we think of, in this age range, the 20 to 50 range, but also patients who are getting cancers that we typically see in patients over 50, like early onset colorectal cancer, and other GI malignancies that now we're seeing in younger patients. And it's really this patient population that, because of these increasing rates, we realize we have to do something.
Filling a need is always important, and that's how the Bridge program developed. So exactly how did it come about, and kind of what does it include, and when did it start?
Yeah, so it really started a little bit over a year ago when I had presented to the James Foundation Board in conjunction with one of my patients who presented his story as a young adult cancer survivor. And really everyone just felt really invigorated by his story and the data that we were seeing with worse outcomes in this patient population. And that really spurred the leadership here at the James to say, we really need to improve our care of these patients and reinvigorate this program that we have into something that's much more comprehensive. And actually, that's when Dr. Myers came to Ohio State, and right around that same time with a similar passion. And I was lucky to be paired up with her to work on this. And sort of over the last year, we've been working together as well as with James leadership and key stakeholders to come up with this comprehensive program that now is, it's finally getting started. So we're really excited.
Wait, before I ask you about how you paired up and how you worked together, that first patient you talked about who went to the James Foundation Board, without giving, of course, too many details, like what roughly was his age and what cancer did he have that would ordinarily a person that age wouldn't have?
Yeah, so he was a younger patient, sort of college age, with an osteosarcoma, which is a type of bone cancer that I treated surgically. And he really talked about the struggles and of recovering and going through treatment at this young age. And as a college student, trying to just get the grades you need and get to class and figure out the social dynamics of being a 20-something-year-old, and then trying to find out, what am I going to do for a job in the future? All of those things sort of pile on once you then have a new cancer diagnosis. And so he was really talking about that struggle of trying to find life within this cancer diagnosis. And that's a big part of what treating this young adult patient population is all about.
So it sounds like the stories and lives of your patients is what drove both of you to want to do this and be so passionate about it.
Mm-hmm.
Definitely.
So then when you say you were paired together to start to do this, what does that mean exactly?
So when I became interested in pursuing a position at The Ohio State, there's a period of, I suppose, courtship where you're trying to figure out if this is a place where you can build a legacy, have a career, be with like-minded people. And when I expressed my interest in young adult and early onset breast cancers or cancer treatment in general, Dr. Alexander's name came up repeatedly, along with many other individuals who are committed to this mission at the institution. And so there were meetings. And in Dr. Alexander, I found a very again, like-minded, compassionate, just good physician. And you kind of recognize that you need to surround yourself with people like that who are good doctors. They're good people. They want to make a difference, not only for each of the patients that they see individually, but for an entire population. And so it kind of, we had coffee, we wrote some notes on the back of napkins, and now here we are.
I love that idea that when they bring someone in new and are recruiting or interviewing someone, they ask you, what is it you want to build here for your career over the next decade or more? And not just, to take it to the next level. And you both had the same idea. So I think that's amazing that James provides those opportunities for people, which I've heard a lot from a lot of different doctors.
It's a remarkable place. I mean, I've been pretty happy here.
Yeah. It's a special place.
So in all these meetings and notes and discussions and plans, what did you come up with? Kind of give us the outline of what the Bridge program includes and what people need to know.
Yeah. So again, this institution is storied. It provides excellent care for its patients. But I think that each individual and each patient has their own story. It's kind of siloed. And so you have to go from one individual to another, one provider to another. And this population of individuals really needs everything orchestrated to make their life easier, to make the treatments better. They also require innovation because it seems, this is true for breast cancer in particular, but it seems that the younger populations have a fundamentally biologically different type of cancer. They show up with more aggressive cancers, more advanced disease. And so not all of the treatment should be the same. But we really need innovation to drive forward a personalized approach to the cancers that these younger populations are having, which exists here. The James has already been doing that work. There are physician scientists who are moving the needle. But in order to make that progress happen faster, to make sure that we are treating patients, preventing cancers in the future, and in many cases curing them, these very smart individuals who were once siloed need to come together. So the Bridge program creates that opportunity where we are trying to marry clinical excellence with community outreach and patient advocacy. A lot of these younger individuals can't keep coming back to the James for their care. So we need to partner with their community providers who really understand the patients. They have relationships that are pre-existing, and then also connect different areas of expertise and research to make that innovation actually happen.
Yeah, and that also involves increased enrollment in clinical trials. This patient population has historically had been under-enrolled in clinical trials, and so that's a big sort of focus of ours to improve access to these clinical trials for these patients, open up clinical trials that have a focus on this young adult patient population, because we know that's the way to move forward. Again, in across many of the diseases, like Sarah or Dr. Myers had mentioned, the outcomes are not quite as good as either the adult or the pediatric counterpart. And so to make real progress, we have to make sure those patients are on these clinical trials to know how they're going to respond to these treatments.
So you've mentioned that the outcomes aren't as good, and you did mention that because they're usually more aggressive cancers. Do you know why that is?
Well, I think it's really multifactorial. Some of the psychosocial challenges that this group of individuals is facing because they are in these developmental stages where they have other obligations to contend with also affect the way that they're able to approach their cancer care. So if you have somebody that is very far distance, for example, from a facility that offers a clinical trial for their rare cancer subtype, it may be difficult for them to come continuously to that institution to enroll in the trial. And so that is an environmental factor, that they don't have access to it.
And they may have young families that they have to care for, or jobs and bills to pay that just make it impossible to sort of really execute a treatment plan.
Right.
Does it also sometimes because colonoscopies and mammograms don't traditionally start till a later age?
Yes.
And
so
these are,
that's
they get it
definitely
before that age.
For younger women with breast cancer, we more frequently find cancers because a young woman has palpated it. So they felt the cancer themselves instead of having a screening mammogram or other imaging that has found it. And so, yes, it is true that there is more aggressive biology to the cancer itself. Sometimes they need different types of treatments. Not all treatment can be applied universally, but there are also these psychosocial factors to contend with. One of the things that both Dr. Alexander and I do research on is something called financial toxicity. We know that if individuals can't afford the treatment, they cut back spending on other essentials, and sometimes they are not actually able to pay for the treatments that they have because they're prioritizing spending for other things, their children, their bills, their housing. So these are all aspects that the Bridge program allows us to treat from a holistic standpoint so that the individuals get the care that they actually need.
We've found that, even the clinicians who are seeing these patients before they get to a cancer diagnosis, oftentimes, it's a 20-something-year-old. Why would they have cancer, right? And so the referring providers, more so because these cancers are rare, and it is rare to see them, there's a delay in diagnosis just because no one suspects it.
Yeah.
Mm-hmm. And I should take this opportunity to say that we're sitting up here talking to you about it, but the Bridge program has so many other individuals that are involved that see this from different aspects. We have social workers who bring a very nuanced approach to some of the care of these patients. We have epidemiologists who are studying, and the reason we've identified these earlier onset cancers as being a problem. And so it's really, I think right now is the right time, but we also have the bandwidth here to actually make a difference, which is pretty special.
Yes, exactly.
Okay, that was a great overview, and we're going to take a break, and when we come back, we're going to hear about some of the research programs you've initiated.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Sarah and John, and let's jump into research. And there's a lot of different areas of research to cover, but let's start with sort of the basic scientific research and how the Bridge program will contribute to that.
Well, I think we can take one step back and kind of explain one of the very nice opportunities that exist. We are pairing with the intramural research program to provide seed funding for investigators who have brilliant ideas, to allow them to kind of cultivate these ideas, generate preliminary data for larger funding mechanisms. And the way that that has sort of been envisioned is to give the opportunities for basic and translational science, also research that has to do with care delivery and health services, and in addition, clinical trial work. So the basic and translational science endeavors are one part of that.
So wait, basic science is like biology of cancer cells. Translational is bringing it to the patient.
Yes.
And then care delivery is providing services to help cancer patients through their journey.
Right.
Exactly.
And trying to understand why some individuals have access to care, others don't, how systems learn to provide resources, and then utilization of that.
Exactly.
Mm-hmm.
Okay, so what's going on in those three areas? It's a lot, so I know it's hard to narrow it down, but give us a couple examples.
Yeah, so there's a lot being done here, and I'd like to call it one of the labs is Matt Clady's lab. So he's a colorectal surgeon here at the James, and he's doing a lot of research on early onset colorectal cancers, and he's actually sort of developed a early onset colorectal cancer program here at the James, which has sort of helped inspire us to expand our patient cohort. But he's doing some really interesting work trying to figure out what's different about the early onset colorectal cancer patients' disease compared to normal patients.
And that colorectal cancer is one of the cancers that I were reading about that is impacting younger and younger patients. It used to be 60 and older, and now it's much younger.
Yeah, while rates have declined as far as incidence as well as mortality in patients over, I think it was 65 years of age.
Because of colonoscopies.
Yeah, they've actually seen an increase, though, in patients who are under 65 in both the incidence as well as the mortality rates associated with those. So it is definitely one of the major hurdles or major cancers that we're really trying to address within this program.
One of the nice things is individuals who are earlier in their careers is to have the senior and more experienced providers and researchers who have been doing this for a long time kind of come into this community and really come together.
And that's honestly the beauty of the James, and something that I when I talk to people about why do I work at the James, it's the people that I get to work with on a daily basis. And I know if it's a clinical question or a research question, I can pick up the phone, or I honestly just turn around in my chair in the lounge and say, hey, I got this patient, can you help me? And at the drop of a hat, they're there to help you answer whatever clinical or research question you have.
Yeah, and I think it also makes the program sustainable, right? You have individuals who have had their own labs, been doing their own research, providing care to patients for a longer length of time, and by having opportunities like this intramural funding and Pelotonia and other organizations that are able to help support this research, you can make the work that we're doing sustainable. The senior investigators are helping the younger investigators to develop their labs, and then it becomes this natural life cycle.
I just want to go back to that concept of intramural research. That's the initial research that leads to bigger funding from like the NCI, and you mentioned Pelotonia. So is this along the lines of the IDEA grants we hear about from Pelotonia?
Mm-hmm. Yeah, very similar.
So how does it work within you, what you're doing?
Right.
Yeah. So it's really hard to get any sort of NIH, NCI, or Department of Defense funding without preliminary data. It just won't happen.
For younger researchers.
Yeah,
right?
Younger researchers, and in a population that is a smaller patient population, although they have excessive or extensive needs compared to some of the older patient populations. It's a smaller group, and these are rare cancers, and so to get funding is more challenging. So really need to get these initial seed grants to sort of allow you to even have any preliminary data to be able to get the bigger funding. And so a big sort of initiative in this program is to provide these funds that hopefully will accelerate research in this space.
Wow, because Pelotonia raised $29 million this year, and it's now, I believe, $330 million.
Yeah, it's incredible what they do.
That kind of sets the James apart to have those resources to do exactly what you just described, this intramural research funded in part by Pelotonia.
Yeah, and it also serves, it serves a few purposes. When research is done, it needs to be done well. It needs to demonstrate rigor. And so by having a process similar to the IDEA grants, you have both individuals who are external to the institution reviewing the science and internally. And so we know that the research dollars are going to initiatives that are truly valuable and worth it, and do have promise for future funding and larger studies. Part of the IRP intramural research program will be that the studies that are funded will be showcased in some capacity. And so individuals will have this opportunity to know what resources are available to them, what ideas are actually coming out from this great work.
By sharing it, they'll find other partners to help them make it even better.
And that's the dissemination piece, right? And then, and for our side of things, where we're doing clinical research and health services research, patients deserve to know what research is being done. They're contributing to it, right? So it's a very nice opportunity to hear, well, my lived experience has caused this change in medicine.
Yeah. Yeah, because I, participated in an interview and provided my opinion, and it's, now the program has totally changed, or, they do this instead. And
or I was on a
changed.
Clinical trial. Or
exactly.
Yeah, so.
Well, you briefly mentioned, and what are you each doing in terms of your research in this area?
Yeah, so we collaborated on a study just recently that's sort of in the process of going through publication now, looking at the experience of sarcoma patients undergoing extremity surgery. There's a lot of research has been done looking at the sort of the experience, getting chemotherapy and just general treatment, but very few studies have looked at what is it like to go through surgery and recovery, and what are the factors that impact recovery and ultimately a quote unquote good outcome. And so we found a lot through that, and hopefully we'll institute some change and sort of help us develop ultimately your sort of a young adult surgery program.
It could actually impact the way surgery is done?
Not so much done, but how we prepare patients for surgery, how we talk to them about the risks of surgery, how we sort of set expectations, and then also how do we help ensure that they're getting the support they need to recover and become sort of as close to normal as they were or as they can be.
One of the very nice findings about that Dr. Alexander study revealed is this idea that sometimes patients don't feel as well prepared for complications that can occur even years down the line from their cancer treatment. And so I always tell patients, my goal is to do one good operation for you. And part of doing one good operation is understanding and trying to prevent some of these adverse events that happen from the surgery, but also other treatments. My personal research looks at how treatment-related adverse events impact long-term financial hardship for this young group of people. Because it's not enough to cure them of their cancer, but if you're going to leave them with a high risk of having future issues, well, that can impact their employment. And if it impacts their employment, the majority of these younger individuals get their health insurance from their employers, right? So now they don't have health insurance for other issues that may arise as they get older. In breast cancer, one of those is breast cancer-related lymphedema. So we do an operation, we take out the cancer, we assess the lymph nodes, which is where we think that the cancer is the first place to spread. And that leaves them with this increased risk of having lifelong irreversible arm swelling. And as you imagine, if you're a young woman who has young children or have a job that you need to use your limbs for, that's actually very difficult. So we're changing our care pathways to try to prevent those complications from happening.
Yeah, that seems to be a trend over the last decade or more, is looking beyond the actual surgery, the impact on the patient, how you can reduce them, how you can improve quality of life for the rest of their lives.
Right.
So, and it looks like that's a key component of the Bridge program.
Yes.
And I think that's across not just surgery, it's everything. The big question is how much treatment is enough to not compromise an oncologic outcome, but minimize toxicity. Is the dose of radiation we're using the appropriate dose for these patients? Is the amount of chemotherapy we're giving the appropriate dose? Can we do less with the same and achieve the same outcome? And I think that's, it's a very nuanced sort of process of trying to figure out what it is and where that happy medium is. But really, our goal is survival, but also living beyond. And that's a huge focus of what this program is. And fortunately, we have a fantastic supportive care services and survivorship program here that really is dedicated to helping patients live beyond and with their cancer diagnoses. So, we were really fortunate. Dr. Myers and I had put together this proposal for this new program. But really the key catalyst to this coming to fruition was Dr. Rathmel coming to Ohio State and coming to the James as the CEO. She has a passion for this patient population. She had a passion for it, in her clinics, but also from a national level in her experience at the NCI. And so really the timing was perfect. And we've been very fortunate to have her support in this initiative. And it really wouldn't be possible without her full support in really helping make this happen for our patients and our clinicians here at the James.
So look down the line 5-10 years, and how do you see not just the Bridge program growing, but just the whole philosophy and knowledge and just in the growing importance of looking at younger people with cancer?
Yeah. So I when you think about it from the different arms of the program, I think from a research standpoint, when you think about basic science, we really want to gain a better understanding of why are we seeing this increasing incidence? Are there environmental factors, dietary factors? What's the genetics of this? And the genetics research is a big component of this, and really build that understanding so that then we can tackle the problem. We'd love to see clinical trial enrollment increase significantly with opening new clinical trials. And so that really from a research standpoint, we can provide patients with this comprehensive sort of research experience where, every patient who's in this age range is on some sort of clinical trial, helping us build the information that we need to treat them. And then I think from a care delivery standpoint, a truly unified care delivery experience for our patients that is streamlined, minimizes disruptions to the patient's life, but also is built in evidence-based treatment protocols so that we say, hey, in young adult patients, this is how we should treat these patients. And I think really that starts with doing the research here, doing the trials here, and then sharing it with everyone else in the country and the world and say, hey, this is how we treat these patients, and this is how we think the standard of care for these patients should be. And I think ultimately that's probably what the goal of the program is to define how patients in this patient population should be cared for, and share that with everyone, and honestly set the standard for how patients should be cared and who have young adult and early onset cancers.
Mm-hmm. Yeah, we hope to create a network of every aspect of care that really integrates, again, these three facets: clinical care, community outreach and advocacy, and research, so that an individual who faces a cancer diagnosis doesn't have to be afraid. They don't have to be afraid of having cancer. They don't have to be afraid of what happens after. They don't have to be afraid for their loved ones of how they're going to find the support for that individual. So this is really a truly integrated approach to holistic care of an individual who finds themselves in a position of having a young adult or early onset diagnosis.
Okay, well, thank you very much for sharing this great new program, and congratulations on the start of it. And your leadership is exemplary. So thanks for filling us in.
Thank you.
Thank you.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.